So the hospital systems are obviously individually responsible for doing what we're asking them to do. They will be reporting to us what they are doing and what they're achieving. Are they meeting the metrics and the goals that are required in the projects? And we will assess, have they met that? And if they have, they'll get the money that is promised under Prime.
Okay.
Yes, we're solely responsible for meeting those. So if our target, for example, is to get to 80% in terms of those that need to be screened for mammography, it's our job to make sure that that happens. And we'll have to coordinate with the plan to make sure that the patients that we think are assigned to us are the same ones that the plan thinks. But the only other thing I would just add to what Ms. Cantwell said is in DSRIP, there really wasn't as much of a connection with our Medi-Cal managed care plans. There is a much more robust connection between Prime and the work that we do with Medi-Cal managed care, not only on the metric achievement, on the target population for who we're measuring our improvement will be in part based on all of those that are assigned to us for primary care. And there is a requirement, as Ms. Cantwell highlighted, that by 2018 we have to have a Medi-Cal managed care contract, and our alternative payment requirements will mandate that we have quality improvement incentives as part of those contracts. And so there's some additional work that's kind of being weaved in, largely touching on what I think of as kind of the sustainability of how we can keep some of these quality improvement efforts moving forward.
And then, because you mentioned earlier in your testimony that what would happen is that, you need to continually improve, which is good. And if you happen to make a really big improvement for 1 year, that doesn't mean you can stop. That's fine. But sometimes, quality improvement is not always just one straight curve. It's something up and down. You hope the mean, the sort of the dots go up and down, but the trend line should be hopefully moving in the right direction. And so I guess one of the questions I have in terms of thinking about patients is that we talk about the consequences perhaps to the hospital or the people participating, but what happens when the outcomes aren't going so well? What do we do to help the patients who are, we can take money away from the people taking care of the patients, but that doesn't help the patients in the end. So what are we going to do to try to address that issue? So for example, more recently, there was an evaluation of outcomes for cancer patients in Medi-Cal. And it showed that those are much poorer than those in commercial plans. In fact, they're equivalent to people being uninsured. I mean, that's terrible. And we know there's specialty care access issues. I'm a primary care doctor, and I know we spend a lot of time talking about primary care, and that's very important, but specialty care has been a huge problem given lots of different reasons, payment rates, et cetera. What do we do if we're not making headway on that? What are we going to do to be sure the patients don't continue to suffer? So it's, we can have a system, and we know this is a lot about payment and money because this is about the federal government, but in the end, it's the patients. We can take money away from people to punish them for not doing, performing, but if those same people are the same people still taking care of the patients, they just have less resources to do what wasn't a very good job to start with and continue to do, and probably even do a worse job because they have fewer resources. What are we doing to give an exit ramp for patients so that they can get the care they need?
Don't want me to answer your question. No, okay, there we go. So I think one of the key things is that this provides us the opportunity to really get detailed data on these types of things. As you know, we have a lot of data in the department. It can be challenging sometimes, but because of the particular focus that these projects have, if we are in a situation where we're seeing, we're not seeing the outcomes we all hope for, it provides us that opportunity to say, okay, so what's going wrong? And how do we work with the system? How do we work with the plan to change whatever's happening? Now, what the right answer is to do would depend on the situation, but I think it really is an opportunity to have additional and more detailed data for us to be able to identify these issues more quickly so that we can try to make changes in coordination with the people who are responsible for the care, the plan, and the providers.
And will the department, I know I've raised this before and other, will the department actually set out performance measures, expectations in advance? So not, well, we're monitoring and it's moving up and down, like this is the goal we have to hit.
Yes.
Right.
So the Prime program has very specific metrics and targets that have to be met that they will tell you are difficult. It's not.
Those are public and published.
And those are public. It's all of that's currently available, as will the reports that they submit on their progress.
Okay. And then I know that one of the things that we're trying to do in the waiver, a lot of pilots, which is good. We want to have innovation. I will tell you, Sacramento County, we have a pilot that dates back called Geographic Managed Care. It's problematic. Probably as a first pilot, there's a reason, but we haven't gone back and fixed it. And so what are we going to do in terms of pilots, in terms of, you do pilots, you want to have different pilots and evaluate what they're doing. Then after you finish the pilots, you then want to bring everyone up to the best ones and not just say, oh, okay, you're stuck with whatever pilot you did, and if it didn't turn out so well, you're just still stuck with that. So what are the plans to try to, I know you do have evaluation, to then say, okay, if we learn from our pilots, now we actually bring up those, the ones that didn't work so well, and try to move them and give those people an opportunity to move into ones. And I'd love to hear, that it's not related to this waiver, and we want to ask this now, when you're planning to fix GMC in Sacramento County, which has been around for how many decades now, and bring that up to speed too. But I won't ask you to answer that question right now, but for this purpose, what are we going to do in terms of being sure we are doing these pilots over the 5 years to you're evaluating them, and then the commitment of the department to then say, okay, we're going to actually give opportunities for people to move to be able to do the most successful pilots. So they're not just pilots anymore. That's what we do across the state.
Sure. So I think, unlike the one that you mentioned, these are clearly time limited, right? There's a start date and end date with evaluations, again, not only at the end, but ongoing. And as I mentioned in the response to Senator Monning's question, part of the role of the department is going to be seeing, as we look across these 5 years, what is working so that we can try to build that into the base Medi-Cal program in the event that we either don't need or are unable to get another waiver. So I think these are really targeted at, let's see what these different things can do. We think they're going to result in certain outcomes. If they don't, let's not continue that. Let's figure out something else to do. But we're hopeful that we'll see the types of things we're hoping to do, particularly with the whole person care, and figure out, well, how do we then integrate that into our Medi-Cal managed care program in a way that allows plans to work with counties and other providers to do that. So that is definitely our goal and our hope. And as you mentioned, we had hoped to do more in our initial waiver proposal. That could have started some of that sooner. We were also disappointed to be where we are, but we still think there are certainly opportunities here for us to learn over the next 5 years, so that when we get to 2020, we're hopefully seeing some of this just built into the program so that it is sustainable going on for those things that are working and not continue those things that are not.
And then I had a question more specifically about, because I know in the analysis it talks about the UCs having to, so I guess the hospitals having to contract with one of the managed care plans, but of course we have different systems, right? So I'll tell you here, and I have a little challenge because I have UC Davis, we have Geographic Managed Care. They're somewhat reluctant to contract for various reasons, some with the Medi-Cal plan. What are we doing? And the fact is we have, some are co's, so they only have one plan, but other ones are 2 plan models. There's 2 geographic managed care plans. So if you only have to contract with one plan, it means a very different thing from one county to another county. Yes. So what are we doing to try to resolve that so that we actually assure access to care for all patients, not just some patients in some counties?
Absolutely. Yes, and certainly Ms. Muller might want to talk about this as well. We agree. We would like to see, quite honestly, every provider in the state contracting with our Medi-Cal managed care plans. We have worked very closely with the University of California to try to work through what are the barriers, what are the issues in contracting. We are glad that there is this requirement that I think helps drive that conversation further. Certainly, I also want to acknowledge, there are differences in the fact that the University of California does provide a significant amount of non-federal share to the program. And so trying to understand both the financial and operational challenges in getting those contracts working. So we are committed to continuing to work with our plans and the University of California, which we have been doing, in trying to encourage those conversations and figure out how do we get to a place where we are in a situation where we're seeing more contracts and sort of beyond just the single requirement that you see here for it to be one plan.
Okay, well, certainly that's, I think, something important to work on. I mean, it's a challenge on both ends because you put in, if you have multiple plans, like we have here in Sacramento County, you have UC contracting with one plan, but also provides a lot of tertiary care. That also means that plan now picks up a lot of much sicker patients. So they're risk base becomes very different too. So, I mean, and same time at the UC side, you know, what kind of, so it's, there's a, but ultimately back to the patients, you know, we need to be sure patients have access. And if we have, if plans aren't able to, you know, come up with things that they can offer that allow patients to get access, we have a problem again in Medi-Cal. And then certainly on the dental side, again, I think, you know, you've seen, hopefully you've seen the Lil Hoover Commission report. And I think that in terms of being able to establish, you know, benchmarks in advance, I mean, they've recommended in terms of a utilization benchmark. And then there's the issue of what happens when you don't meet it, right? And what kind of exit ramps do we have for patients? So we can internally talk about who's at blame and who doesn't get money or so forth, but what can we do to be sure that those patients actually can get the care they need, because that's what we promised them in Medi-Cal. So, but I appreciate the approach and trying to do the whole person approach, and this effort. Just want to be sure that we have lots of things going on, how they're intersecting together, and that we set standards out in advance.
Absolutely.
Okay, thank you.
Before I give it back to Mr. Chairman for more comments or his final comments, I want to ask a couple questions. So I want to first though thank our chairman and the administration for your efforts on the waiver and for this bill. So I'm very interested in bringing dental care to those in need, particularly children. So for the last 6 years, I've sponsored health clinics in my district, and dental needs have been one of the biggest needs. I mean, people wait in line. I remember one time I was there and a family was waiting in line since, gosh, I think early in the morning. And the line, I was walking down the line, and this one child, she was probably like 8, and she was just in pain with her teeth. And so I pulled her out of the line and took her straight in first, instead of having to wait in line. So that's what we're facing right now with DentalCal. So as you know, dentists, of course, you know, in my years, I've met with dentists, and you know, mainly the problem is the reimbursement rates are so low that they lose money when they take any DentalCal patient, and especially children, where children tend to be a little impatient. There's a lot more care to them, and sometimes they would have to get some shots as well, which, you know, makes them a little more nervous for the dentist. And so as you've described the dental transformation initiative, you focus on retaining dentists who are already in the program. While I believe it's extremely important, what your effort, however, we really need to expand the number of service providers. So how does this waiver help us recruit more dentists into the system? And is this initiative available to all counties? And if so, how do I make sure that Orange County and LA County are included or being able to get the benefits?
Sure. So certainly the programs themselves, so some of them are statewide, some of them are initially in certain counties that we're still working through the selection process. But whether you're an existing provider or a new provider, you will be eligible to receive the payment. So as I walk through, like, let's pick the one that's statewide initially, the incentive payment for increasing preventive services utilization. So as I mentioned with that, if you're an existing provider, you're going to have a set target based on your own history to achieve that. So you'll get paid not only for the increased services, just the normal rate, but you'll get a 75% bump on top of that. So a fairly significant investment and additional reimbursement. We are working through, again, with a small stakeholder work group that includes the Dental Association and others to help us determine how do we figure out what the target should be for someone who hasn't participated, so that they still will not just get paid for the service, but also get paid that incentive payment. So we're working through that. That is absolutely a part of the plan, so that it will be available both to existing, but also because we are hoping it will be an incentive for providers who have been hesitant to join the program before to join in because of the ability to earn these additional payments through the incentive payment program.
Thank you.
Sure.
Mr.
I think
Chairman?
we had someone here from the UCs that might be able to address some of the questions.
Thank you, Mr. Chair and members. I just wanted to kind of answer some questions raised by the analysis and also by the members here. First, I would like to say that serving Medicaid is an integral part of UC's mission, and our system is one of the largest in the state in Medi-Cal volume in patient discharges, inpatient days, and outpatient visits statewide. So all UC hospitals are reporting month-over-month increases in Medi-Cal. UC is an important partner also to county hospitals, safety net hospitals, and clinics. Children's Hospital Oakland is a 70% Medi-Cal hospital and is an integrated component of the UCSF Health. Physicians at San Francisco General are UCSF faculty. All physicians, 100%, who practice at the Zuckerberg San Francisco General Hospital and Trauma Center are members of the UCSF faculty. More than 2,000 UCSF physicians and staff from all 4 UCSF professional schools work at San Francisco General. Over 750 full-time physicians at Harbor, UCLA, and Olive View, UCLA are also UCLA faculty, and UC physicians staff specialty care at the new King Drew Hospital in South Central. UC is quickly moving to embrace managed care, and UC has at least one Medi-Cal contract at each location. Additional risk agreements should not destabilize the current delicate financial balance. We understand and appreciate managed care is the state's priority, but health plans passing on unreimbursed expenses is something we must treat carefully. UC's financial commitment to serving Medi-Cal and uninsured is staggering. 35% of all waiver costs are nearly $2 billion are incurred at a UC facility. After netting all payments for the current fiscal year, completely unreimbursed expenses are expected to be nearly $500 million. This includes what we already lose in Medicaid managed care and after netting all waiver payments. These are real expenses that must be paid somehow. UC pays. Unlike local governments, we do not have state and local subventions to cover these costs. We think this commitment is unparalleled and worth protecting. UCLA and UCSF received DISH payments as part of a waiver deal the state cut. In 2005, the state phased out graduate medical education payments to UCLA and UCSF for DISH payments. In terms of Medi-Cal days, UCLA is 4th largest provider in LA County and will likely lose over $150 million in current year alone in providing these services. In terms of Medi-Cal days, UCSF is 2nd largest provider in San Francisco County and will likely lose over $200 million in the current year alone in providing these services. UC is committed to increasing the number of managed care contracts to serve Medi-Cal population, but the contracts have to be reasonable and allow the UC hospitals to remain viable entities. UC must maintain the ability to negotiate at arm's length with managed care companies for reasonable and appropriate and adequate rates for the services we provide. Thank you, Mr. Chair.
You're welcome. Would you like me to close?
Yes, please.
You need to ask for support or opposition.
Any more support?
Michelle Cabrera on behalf of SEIU California and our public hospital as well as our district hospital employees in strong support.
Tam Ma with Health Access and strong support.
Joe Devine on behalf of Ventura and San Bernardino counties, both in support.
Carrie Thomas on behalf of California Association of Public Hospitals and Health Systems in strong support of SB 815.
Julian Voris here on behalf of the Urban Counties of California in strong support.
Barbara Glazer with the California Hospital Association here today in support.
Good afternoon, Brianna Pittman with the California Dental Association. We're here in support, very excited to have an investment for the first time in dental care in the 1115 waiver. I think Ms. Cantwell touched on this in her testimony, but we are also very concerned with making sure that the incentives in the DTI actually do end up with the increased utilization and access that we're hoping for and the very ambitious goals that are set out in the waiver. So we are working with them in the stakeholder group and hope that, if we find out that those aren't working, that there's some opportunity to course correct. So would urge your support for this. Thank you.
Greg Herner on behalf of Alameda Health System in support.
Michael Radigan on behalf of the Board of Supervisors, Santa Clara County in support.
Mike Montgomery, Congress of California Seniors. We support the bill. Elizabeth Landsberg with the Western Center on Law and Poverty. We're in support of the bill and want to acknowledge the very hard work done by all the parties at the table to reach agreement. The last waiver really got us folks enrolled, and now we appreciate the efforts being taken to transform the system and focus on social determinants of health. We share the excitement of the whole person care pilots. We do have some recommendations for strengthening the language in a couple of places. We hope to really put an emphasis on the housing component. We hope that the managed care assessment really takes a look at geographic access. And then the point that's already been discussed by Senator Pan and raised in the analysis about the importance of Medi-Cal members having access to UCs. It is a concern that our local legal aids face, that Medi-Cal members do have problems accessing specialty services. So we look forward to continuing the discussions there. Thank you.
Any further support?
The Association of California Healthcare Districts and the County Health Executives Association of California also support.
Thank you. Any other support? Any opposition? Members, questions?
I had a technical question about the bill. So one of the, an analysis states that the special terms and conditions, which I understand is the agreement with CMS, would prevail in a conflict between this bill. I know it's still, but when the bill gets signed into law, it'll become a state law. And so maybe it's I find it odd that a agreement from the administration could actually trump state law, which of course the governor had signed, or I don't think would be a case of an override, a veto situation, but it's a state law. And so I think it raises some constitutional questions for me. I'm not an attorney, but I do think that an agreement shouldn't trump state law that has been negotiated, that had passed through the legislature. If there is a conflict, then we need to go back and fix the law, if that's what the state law is. So perhaps you can speak to that, but I do find that problematic, and hopefully we can work it out as the bill moves forward.
Sure. So a couple of things. One is that from the federal government perspective, what we're allowed to claim federal funds for is what's in the agreement with them. And so that language is there in the case that the federal government does change the agreement or other things change, because the waiver actually also has to comply with changes in federal law or policy or other regulation. I would also note that that type of language has been included in prior waiver statutes to help protect us in a situation of if we need to make a change, that we're able to do that and not have to wait for a change in state law to allow us to continue the programs that are under the waiver.
And I assume the legislature's notified anytime that happens?
Yeah, so if there were any certainly any significant changes, we certainly always make that information available to not only the legislature, but providers and others who are impacted.
Okay, well, it's just, maybe it's been done in the past. I do find a little problematic that the idea that we pass a law in the state, and yet we put into the law that actually the law doesn't have to be followed if there is a unilateral agreement by the administration, it's the federal government, that, we obviously we modify state law to conform to federal law all the time around here and so forth. We find out, and we have times where we decide we don't want to do that. But that should be the prerogative of the legislature with, the governor, when the governor signs the bill, to make those technical changes or whatever else. So, it may be more convenient to do it that way, but I do wonder about whether that's appropriate or not, and whether that actually is even constitutional, because I think the Constitution grants the legislature the power to make state laws, so to draft state laws. So I just want to make note of that. So.
Thank you. Any other questions from members? Seeing none, Mr. Chairman, would you like to close?
Yes, as you heard, this bill would implement the state's 1115 Medi-Cal 2020 waiver. The waiver renewal is critical to the long-term physical sustainability of the Medi-Cal program and to California's ability to continue to provide high-quality health care to Medi-Cal beneficiaries. The waiver is estimated to bring down $6.2 billion in federal funds over 5 years and establishes a statutory framework for the new dental, prime, and GPP programs. With that, members, I respectfully ask for an aye vote.
Any motion? There's a motion, please. This is due pass to appropriations. Please call for the votes.
Hernandez. Hernandez, I. Nguyen.
Aye.
Nguyen, I. Hall. Mitchell. Mitchell, I. Monning. Monning, I. Nielsen. Nielsen, I. Pan. Pan, I. Roth. Wolk.
Six zero, we'll leave the call open. Just flew all the way over there.
Okay, we're going to lift a call for item number 2, SB 1408, Allen Tissue Donation. Current vote count is 3-0. Do pass as amended. Call the absent members.
Nguyen. Nguyen, I. Hall. Mitchell. Mitchell, I. Nielsen. Nielsen, I. Pan. Pan, I. Roth.
7, we'll place that bill on call.
Yeah, he is. He's wrapping.
Okay, we're going to lift the calls. We're going to start off with item number 1, SB 815, Hernandez, due pass to appropriations. Call the absent members.
Hall. Roth. Roth, I. Wolk. Wolk, I.
Current.
I have a comment. I just wanted to say, Mr. Chair, that I really appreciated the format. I found that it was very different, and it was really well done for a complicated subject. I want to thank you for that.
Thank you.
Okay.
Current vote count is 8-0. That bill is out. Item number 2, SB 1408, Allen, due pass is amended. Call the absent members.
Hall. Roth. Roth, aye.
Current vote count is 8-0, and that bill is out. And that concludes the business of the day, and we are adjourned.